2 tablets, i.e. 150 milligrams, and I see them back in 3 weeks, condition improved नहीं हुई, जी पूछा क्या हो रहा है, ओ जी हम तो एक tablet ले रहे हैं, जब prescription पे लिखा हुआ है, and I usually take the time to explain it to the patient, yet they still don't follow directions. Now, if they don't follow directions after, despite doing that, there's something else wrong with the patient that you've missed. So just don't write a prescription and give it to them. Explain how they're going to take their medication, because that really helps. Obviously, we do know that if you communicate well with your patient at a very practical level, and you're not using any medical jargon such as excuse me, such as asking them for when you fainted, did you have any episodes of incontinence? All right. How many of your patients actually, even the ones who speak English very well, know the what incontinence means? I did that once in my first year of my residency when I was seeing a patient with my consultant in the emergency room, and I asked, we were trying to evaluate for seizures or pseudo seizures, and I asked about incontinence, and later on he did tell me to not use the word incontinence, use losing control of bowel or bladder. So use simple language, and we do know that poor communication between the doctor and patient leads to the patient not being satisfied, and if there is a untoward effect, your chances of being sued are much higher. Obviously, we don't worry about lawsuits in Pakistan. We should. However, many of you are going to be, inshallah, training in UK, US. Well, I don't know about US, but UK, New Zealand, Timbuktu, South Pole, North Pole. So, you really need to be worried about lawsuits. On average, a physician practicing in the US expects to be sued 3 times during his lifetime. All right. So benefits of good communication, you're going to obviously increase your diagnostic skill. You're going to actually decrease work stress because you reached a good diagnosis. And it's going to increase your level of patient satisfaction. It's going to have a positive impact on your patient satisfaction as well. All right, let me just get this out of the way. And obviously, it's going to impact on the patient's quality of life, and we all know what that means. If your patient is doing well, their quality of life is better, they're getting to work, they're taking care of household activities, they're interacting with other people and whatnot. So components of communication, the three types of communication. One is, of course, verbal. What we're doing is a verbal communication. It may be one-sided right now, but it is, after all, verbal communication. I am speaking. Now, the other point is, if you're listening and hearing, you can hear anything. I can hear my doorbell ring, but are you really listening to what I'm saying? Now, that's very important. You need to listen to your patients, both what they're saying and what they're not saying. And what they're not saying is frequently described in non-verbal terms. They might be talking about the issues that they're having at work, and they might not display the correct emotion. So obviously, there's a dissonance going on. So you need to pick up kya ho raha hai, kya nahi ho raha. So non-verbal communication is very important. It's basically how you are sitting, your posture. Are you looking at your mobile while you're talking to the patient, checking on the stock market, etc., etc. So those are all aspects of non-verbal communication. Paraverbal is you're moving your hands, making gestures, if you're making faces at your patient, that's obviously not really going to go too well with your patient who's sitting looking at you. And believe me, patients have all the time in the world. They pick up on all kinds of small things about you. They sometimes know you better than you actually know yourself. So some of the barriers to good communication, what I've really found coming back from the US, especially here, is is basically a language barrier. I think I can speak pretty good English and pretty good Urdu, but a lot of my patients are from Afghanistan, Balochistan. So uske liye phir, obviously I don't speak Pashto or Farsi for that matter. So we use a translator, but a lot of it I'm sure is lost in translation. Ideally, in an ideal world, you should use a hospital appointed translator. We don't have that capacity. ये लोग अपना translator खुद ले आते हैं. Now I've been working with certain translators overall, and they kind of have picked up on the questions I really ask of the majority of patients, and they could really actually do a psychiatric history very quickly and get me the information. So language barrier is a big thing, especially in Pakistan. Obviously, if you don't know how well you're communicating, and what I really recommend is actually interviewing a colleague and having someone else record that for you and seeing how you do during that recording. It gives you a lot of feedback. So you may not have any idea how poorly or well you communicate with other people, and that may give you some feedback as well. The other thing is that obviously if you don't have enough knowledge about the disease that you're treating, you may not be able to communicate adequately. If that situation arises, there are times when patients bring up certain things that they've seen on the internet. I tell them that I will get back to you. I will look it up and I will get back to you. There are times when patients bring all kinds of prescriptions and they're all written in brand names, and I do not remember more than 2 brand names for any given medication. And I frequently pick up my mobile and look it up on the internet. And now, the patients may not like it, but that's their problem. I would rather be safe than sorry. If they have this opinion, that doctor ko kuch nahi pata, theek hai, hey, you lost a patient, but at least you're being safe. The other important barrier to good communication is stress, being tired, bijli puri raat gayi hai because of electric, and you're really exhausted this next day. You're not obviously going to be able to communicate properly as much as you try, but you need to be aware that you're tired, so you can obviously make the effort of doing that. And then the other thing that we frequently face is, especially in the clinic, especially in the wards, during ward rounds, etc., is total lack of time. So if you have a really difficult situation that you need to discuss with the patient, make the extra time, give them another appointment and block it off for just that patient. I frequently do that. I see some patients online and I don't make appointments every 15, 20 minutes. In fact, that whole each appointment session is about an hour. If I finish in half an hour, I have enough time to actually go make some coffee and take a break and watch something on YouTube or whatever. So make time for your patients. If you're hurried and you're trying to communicate a horrible diagnosis and you've got 10 other patients waiting for you in the OPD, ain't going to work properly. Okay? All right. So we need to, how to improve your listening skills? Well, you got to make the patient comfortable, show interest. Mannerisms go a long way, and that's part of the non-verbal communication. When the patient is saying something, I have a habit of interrupting them at times. So you really need to be really careful about what your communication style is. And don't interrupt them while they are saying something, because every patient, don't forget, has a story to tell. Once you get to know the patient well and you've listened to their narrative, you've listened to the history, most of the time you can actually diagnose a patient with just taking a good history. You don't need to do any lab tests. You don't need to do fancy MRIs, CT scan. A good example is patient complaining of coming with headache or facial pain. All you really need is a good history to figure out whether this is a migraine type headache, a tension type headache, a cluster type headache, etc. The other thing that patients don't expect from us, and it surprises me, because 99% of the time they never have any questions. If I have a patient who I think might want to ask me something, I always give them a time कि जी, अच्छा जी, आपके पास कोई सवाल है? But still 99% of the time they really don't have any questions for me. I find that so surprising, which is so different from the patient population in the US. But at least give them a chance to ask any questions that they might have. Don't just abruptly say, okay, ji, here's your prescription. I'll see you in 3 weeks or 4 weeks or whenever, and say, Khuda Hafiz. Just give them a chance to ask any questions. They may want you to repeat the prescription. They might not have understood it. And that's very important as far as patient compliance goes. Okay. When you're conducting medical interviews, pay attention to both the verbal and non-verbal cues. Non-verbal cues mean non-verbal cues. The patients are telling you a whole lot without even saying anything. Always provide them the exact amount of details that is really needed for that patient. That's much better. If the patient is asking कि जी दवाई का side effect क्या है, and you're telling them that your prognosis is 30% 5-year mortality rate or whatever it is, that's not really doing justice to the patient. ठीक है? So patient ने दवाई के side effect पूछे, आप कुछ और बता रहे हैं, please don't do that. And given what the patient wants to know, some patients don't really want to know about their illness or the prognosis or the natural history. So be it. But you need to at least offer it to them. And the other thing is that it's in an ideal world, we need to involve the patient in the decision-making process. It's respecting patients' autonomy. However, in Pakistan, the paternalistic view still carries on. Patients really, for the majority of them, leave the decision making to you. Doctor साहब आप ही बताएं, आप इसके माहिर हैं, हम क्या जानते हैं? And I've heard that so many times. It's amazed me. Even well-educated patients don't take the time to look their illness or look their symptoms up on Google. Not be intimidated by a patient who has looked up their illness. I think an educated patient is a far better patient. And if the patient comes up with, like I said before, if a patient comes up with stuff that you don't know, say, hey, I'll look it up. I'll discuss it with you next time, or schedule another appointment to look it up and then discuss it with them. One of the good things about teaching medical students and residents is that they may know some minute detail that I might have forgotten that I might have learned 30 years ago and forgotten. I said, fine, I don't know the answer. I will look it up. Again, as a word of advice, for whatever professional exams you take down the road, whether it be the American Board of Psychiatry exam or the American Board of Internal Medicine or the PACES exam for the MRCP, if you do not know the answer to a question, please do not guess. The last thing I need is a guessing doctor. I don't need a 007, and I'm sure everyone, at least half the class, knows who 007 is. He has a license to kill. I don't need you to be killing my patients. If you don't, in an exam situation, if you do not know the answer to a question, just say, I don't know the answer to a question. I will ask a colleague. I will look it up. That makes what they're looking for is a physician who is safe. We're not looking for William Osler, who probably knew everything in medicine that had to be known. That's why we have textbooks. That's why we have our mobile phones. That's why we carry textbooks on our mobile phones, etc., etc. All right. Communicating with attendants. Now, the big thing is make sure that you have patients either written or verbal consent to talk to an attendant. If they say, "Nahi ji, you're not going to talk to my mother about my condition," then by all means, you are not going to talk to them. Okay? So going back to the last point in this slide, consent taking is very important. If the patient has not provided informed consent, do not talk, saying, "Ji, aap mareez se pooch lein." So, yeah. When you're talking with the attendant, never be informal, meaning, "Acha ji, inko ye bimari hai, ye kar rahe hain." ठीक है? Explain it to them as you would explain it to the patient. Don't get alarmed if they request a second opinion. I think patients request a second opinion. It's very good. We're not 100% correct. Medicine is still an art, not a science. Hopefully, most of the time we make the correct diagnosis. However, if you're not sure of the diagnosis and if the patient is requesting a second opinion, let them have a second opinion or even a third opinion to see what, if in case you're missing something. There are times when I am not clear about a patient's diagnosis, and I frequently ask one of my colleagues, "Hey, can you take a look at this patient, please, and let me know what you think?" All right. Now, communicating with colleagues. If you're going to reprimand a medical student or a junior doctor, do it in a separate room where it's just you and them, no one else. Okay? It's not fun being reprimanded during ward rounds in front of a bunch of people. If someone has made a mistake, you can gently pull them aside and say, "Hey, you made a mistake. This is what your mistake was. This is how you should correct it." That does not really apply just to the medical students, junior doctors. It applies to everybody on your team. That includes the nursing staff, the para-nursing staff. It includes the ward boy. It includes everybody that's on your team. Okay? They're all equal members of that treatment team. I know many people don't have this concept of working in a treatment team situation in Pakistan, but believe me, many of you who will be training abroad will soon realize that actually behind every good doctor is a far better nurse. So treat everybody with respect. You will soon realize if you've made your nurses happy, they will let you sleep for most of the night when you're on call. They'll take care of the small problems. And when you've made your nurse unhappy, they're going to wake you up at 3 o'clock in the middle of the night to say, can I please get an order for a patient who has constipation for the last 3 days? It could have been taken care of in the daytime. All right. So you will know that you've made your nurse very unhappy. And the other thing I've noticed in Pakistan, we don't give appreciation. You've done a good job, appreciate that person. Let their supervisor know either in a verbal comment or a written comment that this person did a really good job. All right, now there's certain types of patients who are really dependent. They feel that the doctor is going to abandon them, especially with long-standing psychiatric illness, long-standing medical problems like cancer, etc., etc. You really need to make sure and tell them that they're not going to be abandoned, that you will try to take care of their problems as much as possible, as much as humanly possible. However, you need to make sure that you're not crossing any boundary lines. Crossing a boundary line is a major no in medicine, especially psychiatry. You can lose your license for doing that. Okay? And be very careful about seeing patients after hours, seeing patients here, seeing patients there. You really need to see them in the clinic setting. You don't need to be seeing them in Dolman Mall. You don't need to be seeing them in a kebab place, etc., etc. So make sure you don't cross those boundary lines. Now, there are demanding patients, so-called VIP patients. I don't do well with these VIP patients, frankly. I refer them to a colleague. but there's and just remember that you guys are early on in your careers. You don't have to take, as a consultant, you don't have to take every patient that walks in through that door. If you feel that the patient is a patient has a problem that's beyond your level of expertise, or you feel that the patient is uh, causing a reaction in you that you feel might be detrimental to the patient's care and well-being, by all means refer them to a colleague. Now you have patients like physicians who don't want to go through the process of investigations and all that. I think you just need to be gentle, and if they're not going to follow your advice, then refer them to another colleague. You don't need to show anger. Sometimes there's not much you can do with such patients. Refer them to a colleague who is probably more diplomatic than you are. One of my colleagues sees a lot of patients who've been referred by other consultants because they need to be seen ASAP. I don't really buy into that. If a patient needs to be seen, then they need to just get in line and be seen, unless it's a life-threatening emergency. You have manipulative patients. Be very careful of patients who tell you, who've been to multiple doctors, and who come and tell you, okay, after they've seen you, they come and tell you, oh, doctor, you're the best patient, you're the best doctor I've seen so far. I feel that you're going to be able to treat my condition. Be very careful of such patients, because you make one small mistake, even showing up 5 minutes late for the interview, and they will be rejecting you like there is no tomorrow. So you can listen to their problem, and if they are not improving, then obviously either they're not following your treatment, you missed a diagnosis, uh, and in desperate cases, you can get a second opinion. And obviously, anytime you're seeing a patient for any condition, you know the prognosis of that particular condition. So when you're providing them the prognosis, give them realistic information. Patient has end-stage kidney disease. You're not going to say you're going to be playing cricket with your grandson in 5 days from now. So give them realistic hope. Give them realistic information about the illness. Don't lie to them. Don't placate them. Okay? Okay, breaking bad news. I need to get this down. Now, breaking bad news takes a special set of circumstances. It means that it's going to have a devastating influence on your patient's life. Usually means discussing prognosis, especially in oncology, but it doesn't have to be that. It could be someone who has intractable heart failure, multi-organ failure, etc., etc. You need to really take the time to do this. Okay? There are stepwise processes for breaking bad news, and we'll just walk through that. It cannot be taught in a lecture. It really comes with observing a consultant who's done this many times and modeling some of their behavior. Okay, so before you start breaking bad news, you need to know what news that you're going to be breaking. You need to mentally rehearse what you're going to be telling the patient. Please don't go in not knowing the diagnosis, the prognosis, because patients may ask you about this. So again, that rule applies to medical students, junior doctors. Obviously, I'm hoping that no one's going to ask you to break bad news. You need to set time aside. Breaking bad news is not a thing for the OPD when you have 20 other patients waiting. So set time aside. Everyone should be relaxed, sitting comfortably, and avoid time pressure intrusions like your mobile going off, etc., etc. If the patient wants to be with someone, wants to have someone present, then by all means have them present as well. All right. The first step, ask the patient कि जी, what do you really know about your illness, and that way it gives you an opportunity to gauge कि जी patient को कितना मालूम है. ये भी हो सकता है कि patient के relatives ने इनको बताया नहीं कि he's got stage 4 lung CA. So, and then you start blurting out कि I'm sorry, but you have this and this. I really have bad news. We can make you comfortable, and the patient is left devastated. So get to know what the patient knows about his illness. Okay? If you come there to break bad news, patient doesn't know anything about his illness. I would say, wait a minute, we need to stop this right now. Go talk to the patient's family. Ask them कि आपने कितना बताया है. It becomes a whole ethical issue, but that's not for this class. ठीक? Thirdly, ask the patient how much they really want to know. Some patients don't want to know. And so that's their right. However, if they want to know the details of their treatment, then it is your job to discuss the treatment options, risks, benefits, so that they are able to make an informed decision. Okay? If you're prescribing somebody chemotherapy, they need to know and if they're asking kg side effects, then at least you're going to list the major ones. You don't need to list every side effect that's listed in the physician desk reference or in the package insert of that medication, but at least the major ones that you found to happen with your patients undergoing similar treatment. Okay? Again, use simple non-technical terms. Please do not say 30% 5-year survival rate. It really doesn't bode well. It's better explaining, 1 in 10 will live to be 3 years, etc. And if it's really bad news, the other thing you can follow up is that you need to really start planning about your future. Start making plans. And like it says in the second bullet, an initial warning may decrease the shock. So you can say, well, it's not looking good, but we can discuss your diagnosis, your treatment, and we'll make you comfortable as soon as possible, instead of saying, okay, you got stage 4 renal cancer and it's spread to your brain and you're going to die in 2 months. By the way, do never predict when your patient is going to die. You, contrary to popular belief, are not God. So we don't know when our patient is going to die. Tell them, okay, in my experience, itna survival hai, so start making plans, but do not give them an exact date. Never. You need to address your patient's emotions. It may involve holding their hands. It may involve supporting them. It may involve validating their responses. Sometimes patients become silent or tearful. Let them be silent. In a conversation when you're breaking bad news, every minute does not have to be occupied by having a conversation. A lot is said by not saying anything. Sometimes it may just mean holding your patient's hand, making eye contact, giving or passing forward a box of tissue paper. That says a lot about about how you're actually perceiving the patient's emotion. Before you finish breaking bad news, you really need to come up with a treatment plan about the patient's diagnosis and involve the patient's family in the decision-making process as much as possible if the patient allows. If you give them a definite treatment plan, कि जी आपने ये करना है, you're going to meet the oncologist, you're going to meet the radiation specialists on such and such dates with appointments in hand, it makes them less anxious instead of having to go, जी अब appointment लेना है, अब ये करना है. And it sometimes helps to, if it's a big hospital like Yakat, where things have shifted recently, sometimes showing them on a map or a printable map कि जी oncology department किधर है, radiology department किधर है, helps decrease the patient's anxiety and goes a long way. I mean, I've been at Liaquat now 3 years. Now, if you tell me कि जी